As we continue to let people in, my name is Suckow. I'm the executive director of the Liver Coalition of San Diego, and we have been the convener of the Hepatitis initiative in San Diego County since 2018. A role level, and for us, as we transition to a next facilitator convener, and then we'll just continue with our typical leadership role as well as all different diseases. The initiative locally is a public-private partnership between community stakeholders and the County of San Diego, and currently the convener, and has been for 3 years, grant from the County of San Diego, and then also with additional funding from API and Gilead. So thank you to them. This learning exchange has really been about lifting folks up and really sharing best practices. And as we do that, we have so much talent that's happening with Elimination, not just in San Diego, not across the country. So we really use this as a venue to learn from one another and to continue with the process. So with that, I'm glad that you're here. And there's a lot of folks in the room that have a lot of expertise. We've highlighted some regional things at the end. We'll talk about some successes. But to get us started, start nationally. There's so much going on and it's so exciting. And to kick us off is going to be Daniel. Daniel's with National Viral Hepatitis Roundtable. He's probably the most up-to-date person on what's happening nationally and with their synergies and successes. So Daniel, you should be able to share your screen and to forward the slides, and I'll pass it off to you. So welcome.
Great. Thanks, Scott. Hi, everybody. I'm Daniel Raymond. I'm the Policy Director for National Viral Hepatitis Roundtable. Happy to be here. So I'm going to just quickly go through this. I decided to kind of structure these as Hepatitis C elimination conversation starters, suitable for beach parties, cookouts, and summer weddings. And I only have a few slides, but hopefully you'll be able to weave these talking points into all of your social outings and sound convincing and engaging in the process. So let me get my first slide. All right. So let's say that you happen to be at a picnic and you hear somebody chattering about epidemiology and prevention, as they do. Then you can casually say, oh, I heard that about 2.4 million people are living with hepatitis C in the United States, but the total could be as high as 4 million. Now, this comes from a recently published report by authors from CDC and Emory in hepatology. Basically, what they did was they looked at data from a national household survey known as NHANES from 2017 to 2020, tried to factor in likelihood of prevalence among populations that might be missed by a household survey, such as incarcerated people or people who are homeless. But then they also did a calculation saying, you know, we've seen a huge rise in injection drug use over the last decade. If we assume that a lot of those people may not be counted by this household survey, then we might have a lot more hepatitis C than we think we do. So personally, I'm still going with the 2.4 million, but I'm using the kind of phrase could be as high as to highlight that there's still a lot of open questions. Some of you may have seen a report that HepC and NASDAQ put out last November, a surveillance summary report that made the case that public health surveillance for hepatitis C is woefully underfunded, and that a lot of the core practices that we would like to have to make sure that we've got accurate counts, tracks, trends, we just don't have the resources or the staffing for. So that's a little picnic chatter. Now, let's say that you've got your picnic companions on the hook and you want to sound not just casual but informed. You can tell them, apparently you can even look up your state and find estimates for how many people with hepatitis C have cleared their infection. Now, all the references here are in the slides, but recent publication in CDC's MMWR looked at data on a state-by-state basis to estimate how many people have been diagnosed, how many people had signs that they cleared the infection, usually because they'd been treated and cured, but in some cases because they'd resolved natural infection, and came up with different estimates for different states. For the clearance rate, it ranged from about 13% at the lowest to, I think, about 51% at the highest. So really wide range, but a nice way to kind of get a glimpse at how your state stacks up in relative comparison and where there might be more work to do. Now, if you really want to sound like an insider at this picnic, you could say, but I'm worried with all the backlash to harm reduction, the dip in new infections won't last unless we spread the word to support our local syringe services programs. Now, the reference here to the dip in new infections comes from CDC. They put out their 2022 viral hepatitis surveillance report, and they found that after a decade of increases in their estimates of acute or new hepatitis C infections, there is a slight dip from 2021 to 2022. Does that mean that new infections are leveling off? Does that mean that prevention is working? Does that mean that there's a shift in risk patterns? We don't know yet. We'll see how these trends kind of in the out years, next year and after that, shape up. So a glimmer of hope, but the concern also is that in a lot of places, including the western part of the United States, but really all over, we have seen backlash to harm reduction, which has resulted in syringe services programs being forced to cut down or states backtracking on legal approval. So that's something that we should all be paying attention to, and where we get the chance at our picnics, at the swimming pool, talk up the value of harm reduction and the good work that certain services or programs are doing, because right now in many places they're under attack. More conversation starters. Okay, so this might not happen at every barbecue, but let's say that you're hanging out with health policy wonks. Did somebody mention Medicaid? Well, here's how you can start a hepatitis C conversation. You can tell them you want to hear some good news. Over half of all state Medicaid programs have removed prior authorization requirements for most initial hep C treatment. Now, prior authorization is the bane of a lot of healthcare providers' existence, a big barrier to care for a lot of patients. And what we historically saw in Medicaid was that there were enormous hoops to jump through between the provider actually writing the prescription and the patient actually getting the drug, not just filled at the pharmacy, but covered by Medicaid. There's been huge changes over the last few years. And we at MVHR and our partners at Harvard Law School Center for Health Law and Policy Innovation have been documenting that with our State of HepC report, or Hepatitis C State of Medicaid Access. And we've really, over the last few months, hit this tipping point where the majority of states have now cleared the way for most people to get treated without requiring prior authorization and the risk of falling through the cracks that way. So it's important to spread that good news, because I think that's a message that hasn't entirely gotten out there yet. And a lot of people have been deterred from treatment if their first attempt was unsuccessful. Similarly, a lot of providers have been deterred from offering treatment if they feel like they don't have the time or the bandwidth to be faxing back and forth and making calls with the managed care organization to get them to approve the treatment. Now, if you want to sound informed, you can say, I heard some states are even getting federal Medicaid waivers to cover pre-release services and care in prisons and jails. Now, California is one of them. There are 3 others that have been approved, several others that have applied. These reentry waivers, or you might have heard them referred to as 1115 waivers, are really novel, because usually when somebody's incarcerated, they lose their access to Medicaid. And any healthcare that gets delivered has to be paid for by the state or by the county, but you can't tap into Medicaid funding with a couple of tiny exceptions for providing things like hepatitis C testing and treatment in jails and prisons. Now there's a way to do this. It involves getting a waiver approved by Center for Medicaid and Medicare Services, CMS, but there's a lot of momentum there and a lot of opportunities for innovation. Now, if you really want to sound like an insider, you can say, I was just reading a new report from the Congressional Budget Office that says we could save billions of dollars by increasing the number of people on Medicaid cured of hepatitis C. Now, some of you might have seen this came out, I think a week and a half ago now. CBO, the Congressional Budget Office, has been looking at modeling essentially what it would cost to implement something I'll talk about in a second, the White House proposal for a national hepatitis C elimination initiative. And they started with the Medicaid piece. And there was a lot of question in people's minds. Are these numbers going to come out looking good? Because CBO can be very conservative in terms of their assumptions about what will cost the federal government money in the short term versus what it will save in the long term, and they only look out at a 10-year window. So this is good news that we should be sharing with our state Medicaid directors, but also with our congressional offices, that we have a pathway here to achieve really significant cost savings, as well as all the good we can do if we can treat a greater percentage of the Medicaid population over the next few years. And finally, what's all this fuss about hepatitis C elimination? I'm guessing that most of you have heard that the White House did put out a proposal for a national program. It'll be a 5-year program. They envision this requiring legislation from Congress, treating it as a mandatory program similar to, say, Social Security. And so they initially proposed this last year in their budget request. They proposed it again this year too. So they are continuing to back this, and they have people like former NIH Director Francis Collins and his team who are eagerly preaching the gospel of why this would be timely and invaluable. Now, if you want to sound informed, you can say, well, it sounds like Senator Bill Cassidy and Senator Chris Van Hollen have been working on a bipartisan bill modeled after the White House proposal. Now, my advocates friends say that Congress probably won't do much before the election, but we can see action in the lame duck session. Lame duck is typically refers to the November, December, early January period before the new Congress comes in after the elections. And that is the reality that we're in right now, especially in an election year. A lot of work in Congress starts to grind to a halt. They go off on a long recess while a lot of their members are out on the campaign trail. So if you heard something about, oh, Cassidy's working on a bill, Van Hollen's working with them on it 6 months ago, haven't heard anything since then, that's not because it's dead on arrival. It's because they're waiting for Congressional Budget Office to finish the work of calculating the potential cost savings of the bill and looking to be timely and strategic for when they introduce it. But there really is a window of opportunity. So this is why we should be using these conversation starts to drum up interest and awareness about hepatitis C now, because I think there'll be a bunch of work to do towards the end of the year. Now, if you really want to sound like an insider, you can say at least one piece of the White House push is already underway. Rumor has it that FDA could soon authorize a hepatitis C RNA point-of-care test. That could make diagnosing hepatitis C much simpler and even shorten time from diagnosis to starting treatment. Now, right now, when we think about getting diagnosed for hepatitis C, it's an antibody test followed by a confirmatory RNA. Sometimes this can be done with a single blood draw if the laboratory reflexes to RNA, but oftentimes people might get an initial antibody and then have to come back for a separate test. We lose so many people falling through the cracks. A point of care test means you could go to a clinic or even potentially a mobile site, and there will be a device on the van that tests directly for confirmed viremic infection. And if you know that, then you can start the process of saying, what do I have to do to get treated? Your provider can start to work out how can we get you on medication as soon as possible. So this is, nothing is a magic bullet, but this could really be a game changer. And word is that the FDA is likely to make a decision on this summer. So your friends at the cookout will have heard it from you first. In the meantime, maybe you've managed to drum up some interest and engagement and excitement about hepatitis C, and the sense that elimination is actually much closer than it might feel. So I'm going to stop there, but those are my conversation starters for you.
Excellent. Thank you so much, Daniel. Excellent. Thank you so much, Daniel. Whoops. And I think that there are folks that are working on elimination in the room. If you are not on the NVHR mailing list, and I think a lot of this activation as it pertains to this White House plan and this bill, once it gets public, NVHR is a national leadership role. So put Daniel, if you or someone can put how would someone make sure they're on your list? If you're not getting their stuff, go to wherever Daniel tells you in the chat and sign up, because we're going to have to activate quickly as we mobilize to get this passed this year. With that, thank you for an excellent national update, really setting the stage of from a national viewpoint. And there's a global one too, but we're just sticking to the United States today, helping us kind of bring it into California. And we know a lot of states are in different paths on how to move forward. But often California does lead in areas and others we follow. But to talk about California is Rachel McClean, who is with the California Department of the STD Control Branch, and she's the chief of the Office of Viral Hepatitis and Prevention. And she's got some exciting news in her update too. I learned a lot when I saw the slide. So with that, Rachel, welcome.
Great. So thank you, Daniel, for a great presentation. I feel like you always find a nice, fun way to put a spin on things. So if you happen to be at your barbecue, continuing the theme in California, and you want to and you haven't already scared away your companion to go get more macaroni salad, then you can talk about what's going on in California as well. So in terms of the paper that Daniel mentioned, assessing the hepatitis C care cascade by state for the informed barbecue goer, the CDC did publish an estimate of California's hepatitis C care cascade. It's based on data from one national laboratory, Quest Diagnostics. This is the cascade that they published for California. They estimate that, about over a third of people with hepatitis C have been cleared or cured of their infection, and about 10% have been reinfected. But if you're an insider in California, you'll know that Quest Diagnostics is the only laboratory that serves our state prisons. And our state prisons test everyone who comes in the door for hepatitis C, and they're actually treating thousands of people. But we also know that there have been multiple ongoing outbreaks of hepatitis C in our prisons and our jails because we do not have access to sterile tattooing in prisons or jails or safe injection equipment. So we think that this estimate for California is actually an overestimate because the prisons are actually doing a better job testing and treating everyone than they are in the community. But on the flip side of that, I think reinfection rates in the prisons are higher than they are in the community, because in the community, I can go into a tattoo shop, get a tattoo safely. I can go to a syringe services program, get safe injection equipment. And if I'm incarcerated in a prison or jail, I cannot do those things. I included links in the footnotes to several analyses that Quest did, actually comparing the care cascade in California of the general population to the prisons, and some analysis that the prisons did themselves of their own hepatitis C care cascade. They actually have a great dashboard that's publicly available, and it just confirms that this is likely an overestimate. And among people that are not incarcerated in state prisons, it's probably more like closer to 28, 30% of people that have been cleared or cured. So, many years ago, it used to be 10%, so it's better than it was, but we still have a lot of work to do. So, in order to increase the proportion of people with HepC who are tested, aware of their status, linked to care, treated, and cured, we have been allocated money from the state legislature for that purpose in California. And as of July 1, basically next week, there are a number of jurisdictions that are being funded for the first time. Those are highlighted in yellow. So if you live in any of those jurisdictions, you might want to talk to your local health department to see who they're planning to partner with for these new grants. In terms of the activities that are supported, we've tried to make the work plan for these funds as flexible as possible. So the funds can be used for following up on acute, chronic, or perinatal cases of hepatitis C, testing linkages to care and navigation, care coordination, treatment for priority populations, which I'll talk about in a second, and then really building community partnerships and doing health promotion, both with people at risk for hepatitis C, but also educating healthcare providers. One cool thing about these funds is they can be used in a syndemic fashion. So they can be used to offer integrated services for HIV, viral hepatitis, and sexually transmitted infections, along with drug overdose, as well as material supports that people need if they're experiencing homelessness, such as socks or sleeping bags or tents or incentives. In terms of the priority populations, they're really the people that I think of as my people, the people who are most affected by hepatitis C in California. So really encouraging jurisdictions to focus on priority populations and what we call priority settings. So we know that waiting for someone to come into primary care is not going to work for people that have been treated poorly in primary care settings most of their life. So we really encourage programs to go out into the field and find people where they are, and instead of linking people to care, link the care to the people. We also have some other exciting resources. There are 28 emergency departments across the state that are funded to do routine opt-out HIV, HepC, and syphilis testing. And there's a map on the left that shows you where those are at. We also have a cool algorithm that one of my colleagues developed to treat HepC in an emergency department, some new screening guidelines for jails, and a guide for primary care providers. We have a lot of other stuff in the works, but those are some of the main highlights if you want to impress your friends about what's going on in California. And happy to answer any questions, and you're always welcome to be in touch. So I tried to keep it short so we can have lots of time for Q&A, and thanks for having me.
So thank you so much, Rachel. And that was a great overview, and it really sets the stage as we continue to look and get our information for these, I guess, 4th of July parties that we're all going to be out there spreading the word at. And to try to put it in perspective, we'll start with the north, and we'll come down to the south, and we'll talk about some surprises in the middle for organizations or communities that are not part of a structured elimination initiative, but they are working towards elimination within the walls and the boundaries that they have. And so after Jordan talks, we'll do a highlight. But to talk about the HepC SF initiative is Jordan Akerley is the strategic director there. So Jordan, welcome.
So to jump in about one of our milestones with advocacy for HCV surveillance and reporting, one of the reasons we think this is really vital to do is we see that our city level surveillance report is really our roadmap to help us to what Ray shared about really understanding our priority populations and the settings where we really need to focus resources. So we're focusing on presenting data to community stakeholders. We asked our public health department partners to bring this data and really make it available to a multi-sector group of stakeholders from across our initiative. We really asked for a commitment to produce this HCV surveillance report annually. I think as we're coming out of the COVID-19 crisis, really asking for folks to reallocate resources to HCV. And we're really focused on the developing HCV negative RNA analysis and have that be included in our in the city's 2023 report. And then we really want to focus on including and have the city develop analyses that will inform targeted interventions that will allow us to better understand HCV epidemiology in the city to allow us to address critical disparities. Next slide, if you're following along there. So I just wanted to highlight HCV navigation training series. This is something that builds upon what I mentioned about the health access points. So those are seven integrated sites that really endeavor to focus to bring high quality HCV, HIV, STI, and harm reduction and overdose services with 7 different population focuses, and there are sites scattered across the city. And we also know when you're integrating services, a lot of folks are being asked to spin many plates in addition to providing sort of essential or core services like enrollments for food support or other benefits navigation. So we're partnering with the health department to we launched this series to really provide some support around HCV navigation for frontline workers who may not have experience specifically with HCV. So we are pairing that, again, working closely with our partners at the health department on a linkage to care training for HCV. So we're bringing in lots of stakeholders. These are folks from the jail, folks who are working at the Latinx health access point, folks working at the Black African American health access point, as well as a number of different settings. So we're able to build community, build our buy-in around HCV elimination, and really share knowledge with the folks who are on the front lines. I think critically, what we really try to do is center the voices of people with lived and living experience who are really the experts in HCV navigation. And these training series features this expert panel of our navigators. And I think that from my perspective, is really the highlight of this series. And just the next slide, I'll just highlight our navigator program. On the left here, You'll see this is a 12-month view. We run our navigator program in two 6-month cohorts on an annual basis. So these folks do a number of different activities in the community, and I think that that's really illustrative of our commitment to leveraging a syndemics approach to HCV elimination and recognizing that to really do this work effectively in community, that we need to adapt the interventions that we're supporting to meet the needs and the highest priorities of different communities and community-based organizations and the folks they serve. So you can see that there were 59 overdoses reversed by navigators in our program. We had 22 navigators participate over the course of a year. They conducted over 760 outreach shifts, and they distributed over 1,700 units of naloxone. And they participated in many, many more hours and over 4,000 different individual interactions with people in the community. And then on the right side here, you'll see a photo of a workshop that our navigators participated in. This was in addition to our core navigation program and in response to what navigators raised interest in spokesperson training to particularly build skills around policy advocacy. And many of the navigators, I think 11 folks from the program ended up attending and the Epidemics Coalition's Day of Action this past spring. And I'll jump ahead just to the next slide, just to show you a little bit more of other resources that we've been working on. We really believe that it's necessary, especially as folks are back in person, to continue to create resources that are responsive to the needs of different communities. So on the right side here, you see a neighborhood, this black and orange, the back and front of a neighborhood-based HCV information and resource flyer. So on the left side of that second flyer, you can see that there's actually a RIP card that's more like a business card size tearaway that you can use to locate services in that specific neighborhood. And these are translated in English and Spanish for different communities and different neighborhoods that we distribute these to. And then on the left side, we have a flyer that's specifically aimed at providers. We think it's really important to, as we've seen so much turnover in our public health department and different sort of clinical leads on HCV across the city, to continue to cultivate HCV champions, we really need to make sure that they are resourced with the best information possible so that they can engage folks in HCV care and make sure that they're providing referrals to organizations that are really responsive to the needs of the individual person who's sitting before them. And then the next slide is future opportunities. So we want to continue our collaboration with DrPH, particularly on sub-analyses that can increase our understanding of HCV epidemiology in San Francisco. So this includes housing status. We're closely watching California SB 1333 regarding HIV surveillance and data sharing to enable us to really leverage HIV data registries to ensure that we're supporting strong access to a linkage to care for HCV. We also want to grow our workforce development efforts to continue to build the capacity of frontline workers to deliver HCV prevention and care. And I think this really critically involves creating space and co-planning for roles for folks with lived and living experience of HCV. So looking forward to continuing to build upon our work through the Navigator program and through our partnerships with the health department. And I think Daniel had the nod to this, we really want to engage our members about developments related to potential point of care testing developments. We realize if these were to get approved by the FDA, perhaps this summer, there's going to be a lot of work to really ensure that community-based organizations have an understanding of what this means, and that we're really in close conversation with these organizations to understand the strategies that they would need to have support with in order to successfully implement this technology to increase the diagnostics and the uptake in community. And then lastly, we want to continue to explore the use of public health surveillance data to support data to care. We think that this is really critical. We've certainly, for folks who've looked at the LA Times articles, really excited about what's being done in LA and some of the pilots that are being done in San Francisco, and very much look forward to continuing to build upon those efforts. I think it's going to be more critical to do that than ever, given the current fiscal environment and outlook. We really think we need to strategically target the resources that we do have, both through leveraging integrated systems and making sure that folks who are most impacted by HCV-related disparities get access to care in short order. And I think with that, I have my last slide with my contact information.
Excellent. Thank you so much, Jordan. And it was on our end, so thank you for your patience and understanding. We just love the spirit of collaboration and mentorship. We modeled our program in San Diego after the NHEP-CSF, working closely with Katie Burke. You've continued that tradition of excellence. And then I'll just say that our friends in Hawaii, Thaddeus and Heather, provided a mentorship call to Orange County as they're looking at forming officially an elimination plan. So I think the culture of sharing and lifting people up continues. So thank you so much for sharing with us today. With that, we move to our partners in the middle of the state, Los Angeles, and they, I think Brian's probably going to share some good news that they have happening there. We have Brian Risley, who's the co-chair of the Hepatitis C Task Force in Los Angeles, and he's also the manager of HIV HepC for the Health in 5 programs at APLA Health, which is a large federally qualified health center. So with that, Brian.
Great, thank you. So yes, I'm Brian Risley. I'm the co-chair of the Hepatitis C Task Force for Los Angeles County, and the good news that Scott just referred to was that the Los Angeles County Board of Supervisors just passed the motion 4-0. The motion was addressing hepatitis C in Los Angeles County, which is going to direct Department of Public Health to work with Department of Health Services and other relevant departments to provide HepC testing in primary care settings and coordinate reporting, treatment, and testing of HepC throughout the county. This was a win. We'll see what happens with it. All of these motions, have to be followed, and this is, at first feasibility, and then hopefully some funding that we'd like to see go to Department of Public Health. Just a little bit about the HepC Task Force for LA County. We're a group of private and public agencies, advocates, and concerned individuals, and we're working in partnership and collaboration to prevent the spread of hepatitis C and other viral hepatitis and improve the quality of life of persons affected by hepatitis through education on risk factors, harm reduction, and cure treatment. We were established in 2002. I've been a member since then, and grateful for all the advocacy and all the changes that have happened in the HepC landscape. I brought the task force under the aegis of APLA Health, where we can use our 501c3 to raise funds. We were formed to address the lack of services for people at risk for and living with HepC. Members include various federally qualified health centers, community-based organizations. We work closely with the LA County Department of Public Health, medical science researchers at UCLA, at USC, and others. And we work also with the medical science liaisons at various pharma. We meet quarterly, and we've been doing so for 22 years. Our goals are to advocate for HepC policies and funding to increase public awareness of hepatitis, to develop and enhance systems of HepC prevention, surveillance, testing, education, treatment, care, and support. So how have we done that? We've worked closely with Department of Public Health on the last, I don't know how many years of 5-year viral hepatitis prevention action plans through the CDC. I would say this current and next round of funding, we're going to see a lot more action and activity with Department of Public Health under the stewardship of Dr. Prabhu Gounder. And so we are participating in the current 5-year CDC prevention elimination plan. We have produced 20 annual hepatitis C summits in Los Angeles, and these have attracted up to 200 people every year. And we brought together some of the speakers who are on today and others. So we're very fortunate to have people like Rachel support us and others. We have a hepatitis C resource directory that we're currently updated. This is a great resource for clinics, for testing sites, for SAPC sites, syringe exchange programs, testing. So we're currently updating that. We've held 15 annual screening events to promote testing and prevention. And we did about 10 years of legislative breakfasts with Board of Supervisors and City Council. Here's our upcoming annual HepC Summit. It's our 21st annual summit. Again, we're addressing elimination initiatives in Southern California. We're going to be talking about, new innovations in linkage to care, but we're going to describe those initiatives, explain strategies to eliminate new HepC infections among people who are using drugs, and identify ways to integrate HCV testing, linkage, and treatment into FQHCs and other priority settings like jails. Our directory, these are just some of the topics that we cover in the directory. We're going to make this resource available as a PDF that can be updated. So we'd love people's feedback. And then just talk about some challenges. We're a group of volunteers. We're all working in clinics or FQHCs or community-based organizations. This is a volunteer effort. We do have limited resources, so there has to be fundraising every year. There's obviously not enough funds for HepC prevention, treatment, testing, navigation in California, in Los Angeles, in other cities. And the positives are we have contributed to changes in Medi-Cal eligibility and other California Department of Public Health policy through advocacy, through coordination, and we've worked with the LA County health deputies, in this case, working with Hilda Solis's office to pass that motion. So with that, I'm going to thank you, and thanks for the opportunity.
Thank you so much, Brian, for being here. And Los Angeles is such a unique position. So we thank you for your ongoing advocacy there, because it's such a large and diverse market. I think we definitely look to you as you kind of take this huge area and show people, make it into something manageable where you can have impact. So thank you for being here. Next is Andrea Tomada, and Andrea is with the County of San Diego. She's also our vice chair of our San Diego Elimination Initiative. Within the County of San Diego, she works within the HIV, STD, hepatitis branch as a health planning and program specialist. So with that, let me get Andrea on the screen here.
Hi, Scott. Thank you for the introduction.
Yeah.
Go over the successes, lessons learned, and future directions, with more emphasis within the past year. So go ahead and go to the next slide. Thank you. So for our successes this year, we've had a couple of research projects that have been very beneficial in guiding the way we want to move forward with our initiative. UCSD and county colleagues had developed a model for HCV transmission and disease progression. And really, it's just an idea to understand if we are going to meet our targets. Is what we have with UCSD and Dr. Martin and her team. They've put together a model that helps us identify if we're able to meet our target, which is to reduce HCV infections by 80% by 2030. But what we've identified is that with the current situation that we're in, that will not likely happen unless we have a 58% or 54% scale up of services. So this has truly been helpful to help us guide in our future direction. And then also, right now, the model is not yet peer reviewed and will likely be reviewed in 2024. So hopefully late 2024, we'll be able to provide that research to you. Another research study that was done and is currently published and out is a study to investigate the effectiveness of simplified algorithms. That was part of the Family Health Center of San Diego in partnership with, I believe, with Gilead. And if I'm incorrect, please correct me on that. What that does is it provides a understanding of one-stop shop approach in the interest of providing services in non-traditional settings, such as in areas where there's homelessness, or in areas where there's syringe services that are happening. And then still on successes, just on that third slide, just FYI. We also had the in 2024 partnership with the UCSD and Family Health Centers of San Diego. We were able to have do education with our decision makers, and along lines with, and I believe Scott participated in a lot of these education opportunities for our San Diego County Board of Supervisors, Nora Vargas, Tara Lawson-Raymer, and Jim Desmond. So this was a great opportunity to educate them about the model, to let them know that the scale up is needed, and we'll need additional resources to be able to continue to work in our implementation efforts. All right, we can go to the second slide. So on the second slide, it really talks about the lessons learned. And within this last year, we've identified that HCV service integration is definitely needed. We've identified key areas such as for justice-involved services, behavioral health services, substance use disorder programs specifically, as well as integration of services with our service database system 211. And then at some point would like to expand syringe services to include HCV integration. We have one partnership that we work with Family Health Center of San Diego, who does do testing and treatment for HCV with their syringe service programs. Integration is more, and just understanding that integration is not just about screening, and it's not just about testing, it really is about navigation. One of the things that we've identified is that we are in dire need of expanding navigation services so that we can get people into, once they've tested positive, to ensure they get the treatment and care that they need. But we also have to understand that those other barriers are involved. And so navigation services would ideally help with that process. And then also, another lesson learned is we do need the funding. We know that national funding is still, as you probably already heard in previous presentations, is something that's still in the progress. But ideally, we will need more funding to be able to support outreach, testing, navigation services, and treatment. So we can go ahead and go to the next slide. So for future directions, here in San Diego, what we've identified for the next coming year is, and years, because we understand that a lot, before we can get national funding, a lot of the services and resources that we need to support that is going to take time. And so until the national effort sort of is established, we had come up with some approaches that are a little bit that are more effective and resource based. So one of those is to begin a micro elimination effort here in San Diego to identify those who are both co-infected with HIV as well as HCV, and ensure that they are in treatment, and making sure that we are capturing that population. As mentioned, that that the critical challenge that we have here in San Diego is specific to linkage to care and navigation resources, and one of the ideas is to maybe utilize the ECM, enhanced care management, to ensure that coordination of care. Another future direction item that we have here is for educating managed care plans providers about the need for HCV services, and find out ways to improve those related outcomes. And then the next one that we had put in was to ensure key stakeholders from public health services as well as other organizations are presented in future discussion, are present in future discussions, so that we can begin the planning, or at least have that discussion about how we would integrate services in the future. keeping in mind that with the funding that could potentially be coming down. And then finally, we have our model that has identified that we need to have expansion in our syringe service programs. And so we would like to be able to support that by developing syringe services to be able to incorporate hepatitis testing and care. And the next slide is really just my information. And I just want to say thank you so much for your time. And I hope that that we still have time to hear other successes that are in the group. Thank you.
To really meet patients with that, get them tested, treated, and cured of hepatitis. So thank you so much for being here today. Thank you to our speakers. And we will, this has been recorded. We will upload the slides, so the little blips that we experienced here will not be experienced in the tape version, so you can share with colleagues and friends. So with that, have a great day, and thank you for spending an hour with us.